So I'm going to be talking a bit about the anatomy and biomechanics of the cervical spine. Obviously, this is a trauma didactic, but understanding the anatomy and the biomechanics and the kinematics of the cervical spine is pretty important to understanding the trauma and what can break and go wrong. I'm Sapan Gandhi. I'm a attending orthopedic spine surgeon at Beth Israel. So essentially, it's useful to talk about cervical spine anatomy in two basic categories: the upper cervical spine and the lower cervical spine. They sort of behave differently, have different anatomic features, and as a result, the trauma to those two areas are different. So we'll start with the upper cervical spine, which sort of behaves in in its own unique fashion. So the first joint, obviously, of the cervical spine is the occiput to C1 articulation, and this is sort of the first area outside of the skull where cervical spine trauma can happen. This articulation in itself, so the OC joint itself, controls 50% of the patient's cervical flexion and extension. So half of what the patient can do bending forward and bending back happens at this one level. When trauma happens at this level and has to be addressed, it's really vital to get that articulation right. And it's really vital for patients to understand how much motion they may be losing by having trauma at this level. So the OC joint is the articulation between the occipital condyles, which are convex in nature, and the superior articular process of C1, which is concave. So the skull like almost sits like a ball inside of a bowl at C1, or occiput to C1. What you can see here, right here, is the opening of the foramen magnum. So that's where the entrance, or so the exit of the skull and the entrance into the spine. That foramen magnum is made up of the basion, opistheon, and the occipital condyles laterally. So the brainstem exits at this level and becomes the spinal cord as it goes into C1. Talking a little bit about the osteology of C1, you can see here, this is like if we were looking at C1 from the top down, so from the skull into the spine. And it's shaped like a ring. This is sort of the defining characteristic of the osteology of C1. So it is shaped like a ring. So this, it has the anterior ring and tubercle, the posterior ring and posterior tubercle, and then laterally you can see this is the lateral mass of C1. And on the top of the lateral mass is superior articular process that articulates with the occipital condyle. So this is where the occipital condyle sort of sits. Laterally, you can see right here that there's a transverse process. And so this transverse process has a hole in it. And so this hole is the vertebral foramen, where the vertebral artery actually runs. And I'll come back to this because the vertebral artery is sort of intimately connected to the cervical spine, and understanding its anatomy is important to knowing where it can be damaged or there can be a problem with it. But essentially, the vertebral artery comes out through this vertebral foramen. So if we're looking top down in this picture, it comes out through that foramen, and then it runs right here over right over the posterior ring of C1, and then goes into the vertebral foramen. Foramen magnum. And so it's important considering both to identify injuries and also when planning surgery. So this is a different view. This is like sort of from the bottom up, and it shows you some of the other inferior articular process, this will articulate with C2. And again, the block of bone that's in between the superior articular process and inferior articular process is the lateral mass. The next joint down is the C1-2 joint. And again, this is a very unique articulation. It's different than the rest of the cervical spine. And at this level, half or slightly more than half of the patient's axial rotation occurs here. So if you look here, the C2 also has some unique anatomy, which we'll get to in a minute, but the dens or the odontoid process sort of protrudes up, like it's like this mountain of bone that articulates right with C1. And you can see this ligament, and we'll talk about the ligaments at this area as well in a second here. But because of this articulation, it's almost like a, like a top where the C1 can rotate on C2. And for that reason, most of the rotation in the cervical spine comes from this level. There's also articulations between the lateral masses of C1 and C2, like a facet joint. But those joints are pretty flat, so it allows for the rotation at that level. So if we look at the osteology of C2 moving down to C2, you can see that it looks very different than C1. It has this large, the defining characteristic is this large odontoid process or dens, okay, that sort of protrudes up. This sort of goes up into C1 and has an articulation with C1. And then further down, you can see it has a vertebral body right here, okay, and then two lateral masses on either side with a superior articular process that interacts with C1 and an inferior articular process that interacts with C3. There is a spinous process here. So if we're looking at this posteriorly with a bifid, this is the first bifid spinous process right here at C2. And then the lamina connects the spinous process to the facet joint. There's also a transverse process and a vertebral foramen here as well. So the vertebral artery kind of goes up and through that vertebral foramen before it goes over to C1. Relevant to discussion of C2 is sort of the blood supply to C2. So one of the unique things about the odontoid process, or important things to recognize, is that it gets blood flow from two different places, branches of the internal carotid artery, as well as branches of the vertebral artery. And so there is a watershed area right at the base, between the base and the tip of the dens, where the blood supply is not very good. And so this is relevant to trauma as well, because when people get fractures through this area, they don't heal as well. And it's important to understand why that's the case. It's really because of this watershed area at that level. So switching gears from the bony anatomy to the ligamentous anatomy, the occipital cervical ligamentous complex is pretty interesting because it allows that area to be very stable, but allows for a ton of motion. We talked about just a second ago how 50% of the axial rotation and 50% of the flexion extension occurs at these two joints, even though there are seven cervical vertebrae. And so that's really because of the ligamentous complex here. So I'll sort of go through these and identify them for you. So anteriorly is the anterior atlanto-occipital membrane. So that starts over at the skull, runs over the front of C1 and the dens, okay? And it becomes, as it goes further down, the anterior longitudinal ligament. And this is provides anterior stability to, it's more important down in the subaxial spine, cervical spine, but certainly important up higher up too. And up here, it's called the anterior atlanto-occipital membrane. Posteriorly is the tectorial membrane, which sort of runs from the posterior aspect of the clivus, runs posterior to the dens, and comes down the back of the vertebral bodies. This later becomes a PLL. Again, a very important stabilizing ligamentous complex. And then we're sort of in the spinal canal here. And then there's a number of membranes, the apical ligament, the two alar ligaments, and the transverse ligament, which are pretty important for C1-2 stability. And I'll show you that in a second in a different image here. But that's what allows the occiput C1-2 segment to be very stable. So this is a different view here, the C1-2 area. So this is the dens if we're kind of looking top down at the C1-2 joint. So there's the dens, okay? And you can see the transverse ligament, which is a really stout ligament that goes from, one side of the lateral mass of C1 to the other side. It kind of holds the dens against the anterior arch of C1, kind of like a sling. So it kind of holds that dens there and allows it to articulate within that without becoming unstable. The apical ligament, let me see here. So this is like a front on view, or sorry, from back to front view. So the lamina are cut and the spinal cord's removed. And what the apical ligament is this ligament right here that kind of goes from the tip of the dens up to the clivus. And then the alar ligament are these two ligaments right here, again, from the dens, kind of go up like a Y to the occipital condyles. And again, these kind of keep are the primary ligamentous restraints to axial rotation and lateral bending. So very important ligamentous structures there. So, the way we sort of assess these anatomic structures is through radiographic or MRI evaluation. Over the years, there have been many radiographic parameters described of the occipital cervical junction. This is just one table I saw, and you can see how many different parameters there are to look at the stability or the alignment or just the integrity of the occipital cervical junction. So it becomes very confusing. I'll try and point out some of the salient ones. It's not possible probably to know every single one, but a few good ones to be able to assess the upper cervical spine in cases of trauma is a good idea. So here's a lateral view of the occipital cervical junction. And so this is the clivus right here, and this is the occiput right here. And then this is the dens of C2, okay? And then here's the ring, a cross-section of the ring of C1. So there's Wackenheim's line, which is sort of like a tangential line of the posterior aspect of the clivus that sort of goes down, should meet just a tangential line of that, okay? And so the dens should stay anterior, so in front of and below that line. When it doesn't, is often either you should suspect trauma or something called basilar invagination. There's a number of other lines, such as McRae's line, that is essentially just a line from the tip of the clivus to the posterior aspect of the occiput. And this should be the den should also be below this line as well. There are a few other lines that kind of look at similar things, but the other thing to look at is the anterior dens interval. And so that is a space between the anterior aspect of C1, anterior ring of C1, and the anterior aspect of the dens. This should ideally be less than 3. And so when this space is widened, there may be some C1-2 instability. It kind of points to the ligamentous structures that kind of hold the dens in place being inadequate or compromised. And then posteriorly is the SAC, or the space available for the cord. And that's the distance between the posterior aspect of the dens and the posterior ring of C1. And again, that's got to be greater than 13 or 14 to ensure that the spinal cord has enough space to get through this area. And a decrease in that value can sometimes point to there being some sort of instability or compromise of the occipital cervical ligamentous complex. Another useful ratio, is a Powers ratio. And the Powers ratio is really the distance B to C divided by A to D. And when that ratio is greater than 1, it points to a possible occipital cervical instability. What usually happens is that this distance increases and this distance decreases, causing that ratio to be much higher. And so those are sort of the salient points of the upper cervical anatomy. Certainly you can go into a lot more detail depending on what the clinical scenario is, but occiput C1 and C2 are sort of a unique entity in terms of the cervical anatomy. And then after that, the lower cervical anatomy sort of behaves in its own fashion. And so, the lower cervical anatomy from C2 down to C7 can be sort of talked about together as one common topic. So the lower cervical spine, like I mentioned before, kind of acts all similarly. So here, if we look at C2, okay, everything from C2 downwards, you can see is pretty uniform with small changes. This is a sort of a cross section of a cervical spinal segment. And you can see that the vertebral body here is anteriorly. There's an uncinate process that occurs on either side of the vertebral body. In the cervical spine, the cervical levels do have pedicles, okay, but these pedicles are much smaller than they are in the thoracic or lumbar spine and usually don't handle instrumentation. There is a transverse process here on both sides. And this transverse foramen is where the vertebral artery runs, okay? Again, I'll show an image of the anatomy of the vertebral artery, but it usually enters at C6 and runs through these vertebral foramen. On either side is a lateral mass, okay? And the lateral mass has a superior articular process superiorly and the inferior articular process inferiorly. The lateral mass connects to the lamina on either side and which connects to the spinous process. So if you look over here on the sagittal, the important articulations are this oncovertebral joint. So you can see sort of this dome-shaped joint that happens right here, which is the lateral aspect of the vertebral body. The facet joints, okay, so you can see the superior articular process, so this is C3. The superior articular process of C3 interacts with the inferior articular process of C2, okay, and creates this joint right here. And then it happens again at C3, C4. And this block of bone that connects those two facet joints is the lateral mass, okay? It's probably the more stout bone in the cervical spine and why we use that for instrumentation purposes in the cervical spine, posterior instrumentation purposes. You can see here, as far as the spinous process is concerned, the C2, like we talked about before, is the first bifid, and that usually ends at C6. So from C2 to C6, you have bifid spinous processes. So switching gears to the ligaments. So this is a diagram of the ligamentous complexes. So it's important, one, to understand what the ligaments are, but two, also to understand what determines stability. Their model of stability in the spine is a, quote, column model. So Denis popularized this model, and it separates the spinal column into three distinct columns for stability purposes. The anterior column is the anterior 2/3 of the vertebral body, the anterior longitudinal ligament, and the anterior 2/3 of the disc. The middle column is a posterior 1/3 of the vertebral body, the posterior longitudinal ligament, and the posterior 1/3 of the intervertebral disc. The posterior column is really everything posterior to it. So the spinous processes, the interspinous ligament, the supraspinous ligament, and the ligamentum flavum, along with the facet joint capsule. So there's a ton of ligamentous structures posteriorly. In the cervical spine, the integrity of the ligamentous complex here is pretty important at determining stability, because it's what resists the loss of cervical lordosis. So when people have trauma in the anterior and middle columns, the posterior column is what determines whether this will fall or fail in kyphosis. So determining the integrity of that is pretty important. But also keeping an eye on what the different columns are plays a role in evaluating the trauma, and then what ultimately gets done from a trauma standpoint. Radiographically, obviously there are a number of modalities that we look at, and the actual evaluating the traumatic injury will be covered in another lecture, but from a normal anatomic standpoint, we can expect certain things from the cervical spine. So this is a lateral x-ray of the cervical spine, and you can see that the cervical spine's in lordosis, so it makes a nice C here. And then there's a number of lines that show congruence and excellent alignment of the spine. So the anterior vertebral line sort of is the smooth line that connects the anterior part of the vertebral body. Should be a nice smooth line just like this. The posterior vertebral line does something similar on the posterior border of the vertebral body. A spinal laminar line is the junction between the spinous process and the lamina, and that also should be a smooth C-shaped line. And then the interspinous line sort of connects the posterior aspect of the spinous processes, and that also should be a smooth line when you connect them, but also the distances between the spinous processes should be uniform. And what we don't see on an x-ray are the ligamentous structures that I talked about in the last slide, but disruption of those ligamentous structures can cause changes in this distance or changes in these lines. So from a kinematic standpoint, it's important to understand what motion happens where. And so we talked about earlier, occiput to C1, there's quite a bit of flexion extension happens at that one level. At C1-2, quite a bit of the axial rotation happens at that one level. And then from C3 downwards, the flexion extension, rotation, and the lateral bending sort of get split up evenly. So you can see in this is a nice chart that describes that for us. So at every level, there's about 10 degrees of flexion and extension, 10 degrees of rotation, and 12 degrees of lateral bending. And so certainly the effects of fusing or changing or stopping the motion at one of these levels is sort of less significant than the upper cervical level. And it's an important part of the kinematics of the lower cervical spine to understand. So, the last thing I'll talk about as far as anatomy is concerned is the vertebral artery. So the vertebral artery, besides the nerves and the spinal cord that sort of, run through the spinal canal, the vertebral artery is a major vascular structure that's closely intimated with trauma in the cervical spine. So if you look at the artery right here, this is a lateral view. And so usually the vertebral artery enters the cervical canal at C6, okay, and runs through the vertebral foramen through C2 and C1, and then sort of does that circuitous route that I described earlier, where it sort of runs over the posterior ring of C1 before it goes into the foramen magnum. It usually does not enter the spine at C7, and so certainly though there can be variations, and when looking at advanced imaging of the cervical spine, identifying the course of the vertebral artery in that patient is important. One, to identify any injuries to the vertebral artery, but two, certainly if surgical intervention or some sort of treatment is being planned. All right, so that's all I have for the anatomy. Please feel free to reach out with any questions or concerns regarding the lecture.